Moving on to the metabolic enigmas. To chair this session, may I now invite Dr. Inder Kasturia, Dr. Prayas Sethi. Dr. Galot has expressed his inability to be here today. Over to the chairs for the further conduction of the sessions. Thank you.
Good morning, everyone. I welcome all the delegates and my co-chairperson, Dr. Prayas Sethi. And our next speaker is Dr. Rajiv Singla, who is DM from All India Institute of Medical Sciences. He is practicing in Dwarka, New Delhi. And he would be talking about a very interesting topic, which is the most common thing which most of the physicians and endocrinologists deal. It's diabetes, and he would be talking about the diabetes reversal, who, when and how. So I invite Dr. Rajiv Singla sir on the dais to deliver his lecture on this very important topic.
Thank you, Dr. Inder, Dr. Prayas. Very good afternoon to all of you. So my job today is to take you through the process of diabetes reversal. So we've been hearing so much about diabetes reversal in last couple of years or so. So there are both sides to the reversal. There are people who believe that it's a misnomer, the general population is being misguided, while there is another section of people who would really believe that it's actually there, it can be achieved, and we have enough data to kind of support it now. So the way I look at this thing is, so any concept which we can use to benefit our patients should be appreciated, and we should take whatever is positive, and whatever can we use to impact lives of our patients in a positive way should be explored more into. So first of all, the two questions that come to my mind is diabetes reversal possible? So I can tell you that right now, as a concept, yes, it is possible. There is enough data now to support that. Second thing is, why do we need to talk about diabetes reversal? This I'll cover in my last slide. Why do we need to talk about it, and why I'm saying that this concept we can really use to benefit our patients. So this is going to be presentation plan today. So we need to be clear about definitions. We need to be clear about semantics. This is one field where semantics do matter. Then what are the theoretical basis for diabetes reversal? What is the clinical evidence for diabetes reversal? And then can we really identify people who really would be benefited, who, when and how of diabetes reversal? So first of all, we need to be clear about three terms here. One is called cure, another is called reversal, and another is called remission. So cure is like you cure an infectious disease. You've got tuberculosis, you've got malaria, you take antibiotics for n number of time, and then you are rid of that problem. So cure for diabetes is not possible, because this is a complex disease, multi-genetic inheritance with multiple environmental factors coming into together. So you really can't remove that genetic predisposition that any person has. So we really can't cure diabetes. But what we can do is we can reverse, Reverse means that if you see what is your definition of diabetes. So diabetes is defined as your HbA1c, which is more than 6.5%, or your fasting values which are more than 125, or PP blood glucose more than 200 after 75 grams of glucose. So if you can bring any person below this definition and they are not on any medication, so then you practically, that person no longer qualifies for definition of diabetes. So that's what we call as reversal. Now, so if you look at clear definitions, and then I'm coming to remission also. So diabetes reversal in a nutshell means reversing the underlying metabolic abnormalities leading to achievement of euglycemia without continuing need of any glucose lowering medications. So this is a one-step process. Now if you can maintain that process for at least 3 months, so then we say that that person is in a remission state. So you reversed it, you maintained it, and then we call it as a diabetes remission state. So that's how IDA defines it. Nobody has yet defined something called partial remission. So this is my own definition that I use, is an achieving of an HbA1c of 6.5% without any increase or actually decrease in diabetes drugs in our own clinical practice. And this is linked to my answer to my second question, why do we need to talk about diabetes reversal, and then we'll also be covering this in last slide. So theoretical basis, how can diabetes be reversed? So there are basically 3 concepts that we make use of to reverse diabetes. Diabetes, of course, is an interplay of insulin resistance and insulin secretory defect. So in one concept, we need to combine both of them, and then we use both of them to reverse the diabetes. And then the third part is we have to remember that diabetes is a problem of carbohydrate metabolism.
Audio visual, please.
So that's the other concept that we use. Now, yeah, so by the time slides are coming, we should be okay. So if we talk about insulin resistance first. Yeah, thank you. So there is a new concept, although now that concept is no longer new, but in our general discourse this is going to come up time and again, something called overflow hypothesis or personal fat threshold. So what basically we believe now is that everybody, every race, every individual has got their own personal fat thresholds. The amount of fat that anybody can hold in their subcutaneous tissue, the amount of fat that people can hold in their visceral adipose tissue, the amount of fat that people can hold in their liver. So whatever energy that we take, either in form of carbohydrates or fats, excess energy body stores in forms of triglycerides. So till the time body can store in different store parts, it stores. And when those stores are filled for any particular individual, according to their own thresholds, it gets spilled over into circulation. They goes to insulin sensitive tissues in form of free fatty acids and then cause insulin resistance in there. So theoretically speaking, if we make body lose those triglycerides or fat stores, you create more space in those stores. So those free fatty acids which are free and going to insulin sensitive tissues, they can get stored back in your storage tissues, the subcutaneous tissue, and then of course your resistance levels should come down. But over and time again, now it has been shown that it is not that losing weight at any stage is going to be useful. It can only be useful if you still got those beta cells which are working. So if your insulin secretory capacity is still there. Earlier what we used to believe was that whatever beta cells are gone for life for anybody, and it's a progressive problem. Now what science has revealed over time is that there is something called beta cell dedifferentiation in response to the pancreatic fat. So you've got something called twin cycle hypothesis, and Dr. Deep has got a plenary session on that, so I'm not going to dwell on that much, but basic concept is that as your visceral adipose tissue, as your visceral fat increases, so more and more free fatty acids go to pancreas, gets deposited there, and that pancreatic fat is responsible for beta cell dedifferentiation, and that's a reversible process. If you remove that fat from pancreas, your cells differentiate back to beta cells, your insulin secretory capacity comes back, and which contributes more insulin in the circulation, resulting in again beta cell differentiation. Now, of course, ketogenic diet, low carb diets, your type 2 diabetes is a problem of carbohydrate metabolism. If in a selected subpopulation, if you can remove those carbohydrates from diet, you have actually bypassed the entire metabolic process. So of course your dependence on medicines and everything is going to come back. It's not as simple though, because it also leads to reduction in your weight, which also eventually contributes to the impact on insulin resistance as well as your insulin secretory capacity. But yeah, that's also is a very, very effective way to go about it. Now, the clinical evidence, of course, I think Dr. Taylor is the one who actually gave us twin cycle hypothesis. So there are 3 studies though I would like to mention. They're not new studies, but counterpoint study, basically just done on 11 patients, was one of the first studies which kind of with data showed that if you give people very low calorie diet, then their diabetes can be reversed, right? Then the second study was counterbalance study from same group, in which we try to look at what is the difference between responders and non-responders. So what are the factors which can tell us whether diabetes can be reversed in one particular person or not. And the direct trial, more recent trial, so whether this approach can be used in primary care, and then can these people be maintained for a long time. So just a very brief reference in the counterpoint study. If you look at the graph on your right side, okay. So what we see here is in the graph, the B graph is basically your insulin secretion in control population, and then C, D, E and F are your graphs when people are subjected to low calorie diet over time. So what you realize is that insulin secretion rate over the time, as people lose more and more weight, in graph F and B, they looks exactly similar. So with this, they can actually prove that your insulin secretion rates can go up as your weight goes down, as you put people on low calorie diet, in matter of weeks. Not in matter of months, but in matter of weeks. Now, direct trial, 306 individuals were given low calorie diet, 825 to 853 kilocalories, given over 3 to 5 months. All their medication stopped even before they were put on any low calorie diet. And then they showed that 46% of people in graph B, 46% of people in intervention group could be maintained without any drugs for a year. And then 6 months down the line, they were all, it's not that they were all kept on low calorie diet for entire year. And then the people, when they lost more than 15 kgs, 86% of people who lost 15 kgs or more achieved diabetes remission. So what we did was, so we thought, okay, so all these things are done in a clinical trial. Can we really replicate this thing in our own setting? So this is our first brief data that we've done at our own clinic. Is we took 56 people, approximately 43 years of age, 27 of them new onset and 29 with a mean duration of diabetes of 5.75 years, with a weight of 91 kgs, BMI of 33, and their baseline HbA1c was, mean HbA1c was 8.82 centimeters. And then if you look at, that was the distribution of medicines that they were on. So large majority of them were on just one medicine, but they were on 2 medicines, 3 medicines, and then 4 different drug classes that they were there. And then we put them in a 3-tiered care, but it's all practical. Like, so we didn't really do it in a clinical trial kind of setting. So people used to meet me once in a month. People used to meet our senior dietitian once in a week, and then there were 2 health coaches who were junior dietitians. They were in touch with patients all the time on an SOS basis. And then all of them were given diabetes education and no particular diet regime, no low calorie diet, no ketogenic diet, but we just try to individualize it for them. So this is what we achieved at end of 3 months. HbA1c came down in these 56 individuals from 8.82% to 6.4%. Overall, there was 7.29% body weight loss. But then if you look at those requirement of medicines, now you see the entire graph has shifted towards up. 22 people now were off medications and 15 people were on just one medication. And then the requirement of medicines came down, and then 21 out of these 56, 37.5% of people in 3 months were off medications. Now, similar results are there on low carb diet also. It's not that their results are better than this, but 46% in clinical trial, way 37% in our own trial. So similarly, 30-35% people who are on low carb diets go off medications as an when given in a diligent manner. So so with that kind of, we believe that diabetes reversal is possible, and even in clinical scenario, it is possible for people to go off medication and maintain HbA1c less than 6.5. So next question to us was, can we really identify who are the people who are going to be benefited more? So can we offer it to everybody, or do we select people? So then we try to look at as to what are the factors in these people who was kind of we can predict as to who's going to go into reversal. So their baseline weight didn't matter, their baseline BMI didn't matter. So we initially thought that the people who've got higher weight, higher BMI are going to get reversed more. So that was the common sense, but that really didn't matter. What their HbA1c was to start with, how many numbers they were on, and what their fasting blood glucose was. So basically what all 3 of them were indication of what their residual beta cell function was. So they were all positively correlated with remission. What is their duration of diabetes was single most important factor. So duration of diabetes we actually associate with beta cell dysfunction reversibility. So that we told that the beta cell dedifferentiation that happens after a certain period of time, you really can't bring those beta cells back. So then that's function of that. And then visceral fat, which we did with electrical impedance in all these people, then we realized was that also was significantly correlated with reversal. But then change in weight and change in BMI as in direct trial was correlated with diabetes reversal. So more weight you lose, more BMI your comes down, and then so more chances of reversal that's there. And then similar things are there in those counterpoint and counterbalance trial also. Only thing that we need to, I just want to emphasize one point here is that losing 15 kgs weight in somebody who's got diabetes of 4 years duration and into somebody who's got diabetes duration of 14 years are 2 different things. So losing same amount of weight, bringing that insulin resistance down in somebody who's got 14 years of diabetes may still not reverse their diabetes, because their beta cell function is not going to come back. But for somebody who's 4 years of duration of diabetes, is highly unlikely, more than 90% chances I would put, that they would go off medication. So these are important because that's how you counsel people. That's how you're going to tell. It's not that losing that weight in 14 years duration of diabetes is not going to be useful. And that's where your concept of partial remissions comes in mind. For somebody as a patient to explain this concept can really motivate them to go ahead and do that also. But from scientific point of view, from reversal, I think duration of diabetes is one single most important factor which tells you who can be reversed, who cannot be. So based on this, we kind of decided to put that all these things in a parameter form. So what we believe is that apart from disease factors, vis-a-vis residual beta cell function and beta cell reversibility, care team factors, if we have an intention to reverse, on these settings, 40% of people could reverse. While in general care, only 5% of people are off medications at any point of time. Then patient activation factor. So we can only do as much people are motivated. So only motivated people we would be able to reverse, because it's largely based upon diet and exercise that they need to follow. So last part of my talk is a very brief how. So I think we've already seen that very low calorie diet or low carb diets are the two basic approaches, but sometimes these becomes impractical in our day-to-day life. So what we tried to do was a combination or an individual diet strategy in the people that we followed. So, and this is what we gave them. What we did was we recorded their 24-hour recall over the 3 months time that we gave them. So if you look at baseline, they were on almost 24 kilocalories as a mean. They were taking 258 grams of carbs, and then over 3 months their calories came down, but those calories came down largely from carbohydrates, but they are still not anywhere near to the definition of low carb diet. So it's kind of approached, combined approach kind of a thing, where your calories come down, where your carbs come down, but your protein and fats almost stay same over 3 months of time. So again, we proposed in same review article recently published is that now we are listening more and more about diabetes subtypes. So depending upon what subtype does your patient falls in, so you can actually individualize. For somebody whose BMI is really low, doesn't have much weight to lose, perhaps going differentially, I'll finish in a minute. So going differentially on cutting down their carbs would give us more disproportionately better results rather than cutting on their calories, because we don't really want them to lose weight. While somebody whose weight is already on higher side, age is little on the higher side, so then going with low calorie diet may actually be more useful. So diabetes reversal is possible in clinical practice. People who need less number of medicines to maintain their glycemic control in early years of diabetes are more likely to reverse, and individual diet plan, but a continuous care is needed. So just to answer last question as to why do we need to talk about diabetes reversal. So first of all, we need to acknowledge here that contrary to what we commonly believe, lifestyle therapies does work in practice if we do that in a systematic manner. We need them now more than ever, because we showed from our own clinic that the people who come with new onset diabetes, at least to my clinic, are in 30 to 35 years of age. So they've got a long life ahead with them, and with number of medicines that we have, it's very, very difficult to keep them healthy for 30 years, for 40 years or 50 years in future. Yeah. So thank you.